Make sure I know how to share my screen.
Well, yeah, I'll show you how to talk. There's a little green button down there. You can do once you're ready to do it. So,
Okay.
okay, so let's go ahead and start the webinar and get going here. So, well, hello. I am very excited tonight. We've got a great guest here. Sarah Hyland is with, she's clinical liaison with the Indianapolis Rehabilitation Hospital. I had the chance to go to a networking event. In fact, I got my dinner there with a chili cook-off the other night, which was great. But I learned about this hospital I didn't even know was there. And I drive by it all the time, but it's back off the road. I didn't even know that you guys existed. Very cool place. So, man, I'm with Life's Co-Pilot, we're always trying to find information that seniors and their families and their caregivers could really use to improve the quality of their life and what have you. And rehab, to me, is a personal pet peeve. It's just, I don't think people realize, but when you get to be senior, towards the 80s and what have you, rehab becomes a big part of your life. It's a very expensive part of your life. And it is also one place to another is very different to the experiences that you will find. So, Sarah, why don't you tell us a little bit about Indianapolis Rehabilitation Hospital? Let's start there, and we'll kind of visit for a minute.
Yeah. So we are newer, definitely compared to some of the other rehab hospitals in the area. We've been here for a little over 2 years. And like you said, we are tucked back. Once you find us, it's easy to find us, but we are right behind 2 facilities in the area, and we're, like you said, an inpatient rehab hospital, which I'm gonna kind of go in more detail about what that is exactly.
Well, very good. 2 years, so I don't feel quite as bad.
No, we're newer.
Yeah.
We're still getting known out there. We're in the growing phase for sure, but we're doing really well.
And you're Indianapolis Hospital, but you're in Carmel. So,
Yes.
So there's that to figure out as well. So yeah.
And some people in the area call us Carmel Rehab. It's Indy IRH, Indy Rehab at Carmel, whatever you want to call it.
Okay, just go find us, right?
Yeah,
So that's where it comes down to. Well, so tell me about Carmel. Tell me about your community and what your hospital and what it is, and then we can talk more about rehab in general. So
Okay, so inpatient rehab is what we are. We're an inpatient rehab hospital, so we're still an acute care hospital. Patients see a doctor every single day. We have physical PM&R docs, so they're physical medicine and rehab docs that see our patients Monday through Friday. One of those 2, we have 2 on staff, and one of them is our medical director. He is Dr. Dugan, and his bread and butter is amputations. He has a lot of knowledge with orthotics and prosthetics. He was at another rehab hospital before we opened, and he even developed an individualized amputation program. So part of my job as a liaison, whenever I get a referral, is I get to assign the doctor. So that's part of it too. Anytime someone has an amputation, I'm automatically thinking Dr. Dugan. Our other PM&R doctor is Dr. Zuziak, and he was actually the medical director at Lafayette Rehab Hospital in West Lafayette before we opened. And then he came here when we opened up, and he is, like I said, a PM&R and also board certified with spinal injury. So sort of the same thing. If I have a patient with any type of spinal cord, I'm thinking ahead and assigning that patient to Dr. Zuziak. And then on the weekends, so Saturday and Sunday, patients are seen by an internal medicine doctor. So that's kind of a little piece of how we are still an acute hospital level, but the rehab hospital piece comes into play because the amount of therapy is just so different. It's intense, and the fact that it's 3 hours, 5 days a week, so 15 hours of therapy a week. But it's broken up, of course, throughout the day. We're not working people out for 3 hours straight. I don't know anyone who would want to do that. And then we have still a multidisciplinary team, just like in acute care hospital. We've got PT, OT, speech therapy, respiratory therapy, dietitian, just kind of the whole picture. But another difference is instead of just working on getting medically stable, like at a acute hospital that you might think of when you think of the word hospital, our goal is to regain function so that patients can get back home safely, get back to work, get back to their life.
So how do people get with you? Do they get signed over from the hospital? Do the doctors, or can someone go, hey, I need help, and then contact you directly?
It's really across the board. So us clinical liaisons, there's 7 of us total, and we each have a territory. So for example, my main hospital is St. Vincent 86. I also have Ortho Indy, I have Indiana Spine Hospital, and I have Seton Specialty Hospital. So I have kind of gotten to know the case managers there. They have my number, I've got their number. A patient is at their hospital and their therapy team will evaluate them, and they're being seen by a team of doctors the whole time they're there, and the therapy team and the doctor might make the recommendation of, you need a rehab hospital, you're not quite ready to go home yet. And then normally the case manager goes in and meets with the patient and shows them, this is the list of the rehab hospitals in this area. And then patient and family make their choice. And then I get the referral from the case manager, go over the clinicals, meet the patient, tell them about our hospital, and then do all the paperwork, getting them admitted if they do choose us, so that when the first, second, third here, the doctor that's going to see them, the nursing team, the therapy team, everyone knows their story. That's kind of the biggest role of my job, is kind of writing their story, is what I call it. But we do get patients. We can admit patients from home. We can admit patients straight from the ER. That looks a little different, of course. There's a couple different things that we have to get from maybe a home health company, if they're seeing home health at that time. But yeah, we don't need a 3 midnight stay for
Okay, let's
subacute.
repeat that right there, because
Yeah.
I didn't want to bury that lead, because that's what
Yeah.
blew me away when I met you guys.
Yeah, so subacute, which would be like rehab at a nursing home, they didn't during COVID. They did not require the 3 midnight stay, but now that, we're kind of out of the thick, thankfully, of COVID, they have gone back to needing the 3 midnight stay. So at our level, we are a hospital, so we do not need 3 midnight stay. If a patient has traditional Medicare, we can evaluate them from the ER. And like I said, if they're at home, maybe they were at St. Vincent and they were thinking about rehab, but then they decided, no, I want to try to go home, and it's not working out. So we can admit them that same day from home, or maybe they're in the ER and they're thinking about going home. They're not going to get admitted. Physical therapy has evaluated them and kind of saying it could go either way. We could admit them from the ER.
Well, this is why I wanted to have this conversation, because unless you've been through it, you probably have no idea what this means, what you're just saying. Okay.
Yeah.
But we've been through it. And for instance, there's all these things where you're cajoling and begging the doctors for a stay at the hospital. Okay.
Right.
There to be able to qualify. My mom, I think it was last year, she ended up doing about a 2 to 3 month stay actually, she was just kind of rotating between emergency rooms, rehab, emergency rooms, then finally hospital,
Right.
whatever. But for the first month, she had to private pay, which that's, I don't know, $30,000. I mean, it was not something that you just, sneeze at, right?
Right.
So,
Right.
and a lot of people, there's no way that's going to happen, whatever.
No.
So,
Yeah.
so that's something that I just was totally taken aback. I guess because you're a hospital, you have a different set of rules, right?
Right. So if it's traditional Medicare, we can just admit them if appropriate, of course.
Right.
But if they have a commercial plan like Aetna, or an Advantage Medicare plan like UHC Medicare, Humana Medicare, you might end up being there for 3 midnights anyway, because we do have to reach out to insurance and get authorization to say that they are going to pay for the stay.
Okay, so that's a good question. We kind of went into that. And I don't know if you really are able to go into much detail on this or not, but if you can't, just say we'll have to, and I'll get somebody else in to have to answer this.
Yeah.
But that's one of the things that I hear a lot in the profession of the rehab profession, and people that are in it, when I see them like socially, okay, where they're
Mm,
talking a little, their hair down more, okay,
right,
yeah.
right.
They're such big advocates of the actual traditional social Medicare versus the different kinds of plans that are, that are popular that you see on TV all the time.
Right.
Because they say the big dropping point is that rehab, that all of a sudden it becomes very difficult to get that paid. Is that true, or?
Yeah, I mean, I don't know that it's difficult. I'll say there's just more hoops to jump through.
Okay.
Those Advantage plans I think are more affordable. I'm not super knowledgeable in what the breakdown there looks. So I think up front, if you don't need the rehab stay, it would make more sense. But whoever knows if you're going to need it.
Right.
But we do have to get authorization. So we kind of have to reach out to insurance, and kind of like that story I was saying, we then are explaining to the insurance company why this individual needs our level of care. And it just kind of can delay the process as well, because, they take 48 to 72 hours to hear back to get back to us. And then sometimes maybe the patient has improved enough to go home with home health, you know, or maybe insurance says no, they don't always approve for this day.
Well, that's the part I've heard, is that the Advantage plans are great unless you get stuck in that rehab, which, by the way, what I'm finding is dealing with two octogenarian, well, actually one's 90 something now. Rehab becomes a fairly common part of your life,
Yeah, yeah,
yeah.
yeah. One little like UTI or can really cause some havoc.
Yeah, and then once you're in there, you have a tendency to be in there for a while, to get your
Yeah,
strength back and what have you.
sure,
So yeah.
sure.
Well, so tell me, so you guys do all kinds of physical therapy. Let's stop there for a second. I just was having a conversation literally a half an hour ago with my neighbor. I said I'm getting ready to do this video,
Yeah,
and I made a comment that that you're a rehab hospital, and I think a lot of people that are not dealing with the elderly immediately flash to drugs and alcohol rehab as
yeah.
opposed to the physical rehab. Could you explain, I mean, really the differences? I mean, if you've lived there, you know what it's all about, but it's kind of go through that a little bit so people don't
Yeah,
get confused if they happen to see this.
yeah. I don't know. Yeah, we're called an inpatient rehab hospital, but we are not drug and alcohol rehab. We have had people call refer because we do take self referrals as well. And we have had that question. But yeah, we don't do drug or alcohol rehab.
Well, one of the things that I have found with dealing with my own family members in the process, if they go in there, get down, and they get knocked, my uncle just fell and broke his shoulder. That's,
Mhm.
he used the walker. Well, that becomes a bit of a challenge, if you can't, use it. In different situations that have come up, it doesn't take very long to be in bed before you're really needing rehab to get strong enough to function. And the best, and this is, my wife had a surgery. She had like a bleeding ulcers, and so she was in, for a period of time in the hospital. They were dealing with that, and she was complaining to her doctor about how weak she was and how she just couldn't get back. And he made a comment that has stuck with me: is for every day you lay down in a bed, it's 7 days to get your strength back. Okay, well, and then when you're
Yeah.
probably 80, 90, that makes it even more complicated.
Yeah, the research there is wild. But that is what I've been told as well. Which is kind of what the biggest difference in an inpatient rehab hospital, or we call ourselves IRF, inpatient rehab facilities. That's the big difference in our acute hospital type versus what most people probably think of, like IU North, St. Vincent, those kind of trauma hospitals, those big community hospitals, because there's just so many more people there. So, therapy is only able to see you for maybe 15, 30 minutes, 3, maybe 5 days if you're lucky. So yeah, that's again just one of the biggest differences between our level of care with doing the 15 hours of therapy a week.
And so you do basically all kinds of physical therapy and things along that line as well. It could be,
Yeah.
you know,
Yeah, most of our patients see physical therapy and occupational therapy, which one of the requirements for our level of care is needing two disciplines, and almost everybody's getting PT/OT. We also have speech therapy, and the way that we do it at Indy Rehab Hospital is you're still getting your 3 hours of physical and occupational therapy, and then if you need speech therapy, it's just a little extra. So you're going to be extra tired.
well, speech therapy, that's a good thing to go into. I'll never forget the first time my uncle was in was in rehab.
Oh,
He had
the
dark
lights turned off. It's an automatic
so
light. I'm probably gonna have to do that a couple times.
you have to move. Yeah.
Yeah.
So yeah. Um, so the first time he was in therapy, all of a sudden they told me they were going to put him on, speech therapy. And I'm like, this has been before I got into the senior world, started understanding more of this. I'm like, he didn't have a speech problem, so I couldn't figure it out. He actually had a thyroid problem and swallowing. Turns out that they were teaching him how to swallow. He had been told he was going to either have to have surgery or he was going to have a feeding tube by the surgeon. And we basically fired the surgeon because we didn't want to do any one of those things, and that's all he was fixated on. So, but the speech therapy taught him how to eat. And this was 1987. He's had no or 2017, I guess it was. And so he's had no problem since then. Okay. So, so I was amazed. I learned that speech therapy is not just speech. It's basically everything from what I understand, like the middle of your chest up. Isn't that correct?
Yeah, so I'm actually a speech therapist.
Okay.
I worked bedside for 7 years before I started this role. And I worked in home health care and I worked in nursing homes. And I wish I had $1 for every time I walked into a patient's room to say, "Hi, I'm Sarah, the speech therapist." And they said, I talk fine.
Yeah.
But yeah, but we do a lot of swallowing, and especially at our level of care in rehab hospitals, because we do get a lot of patients who have had strokes or, a spinal cord injury and a brain injury that have affected swallowing. So we do work with a lot of people on swallowing, or again, stroke. Maybe they're having aphasia, so trouble expressively or receptively communicating, and also work on voicing as well, and cognition. That's a big
Yes, I was
piece
going to
of
say that
as
was part of
well.
it too. Yeah.
Yeah.
So, and then the other one is, like for instance, my mom's got Parkinson's, and so,
Mhm.
working at projecting, and there's a big challenge that Parkinson's patients have sometimes in that area
Yes,
as
the
well.
LSVT loud, that's a really big program for Parkinson's patients.
Yeah. Right. So, well, like I said, I'm very excited to find out that you guys exist. Okay. Number one. And number
Yeah.
two, that you can do these different services. So what's it like trying to get in? Is that, one of the things that I have found trying to find things for my family members is finding a bed. So how available are you in most cases?
Yeah, so we're a smaller hospital. We are 40 beds. They're all private rooms. And it's kind of just a constant moving piece. We internally we manage it. We have two amazing case managers who are super involved from like within the first 24 to 48 hours. They're meeting every new admission, and then they're communicating with the patient's therapy team and the doctor on, kind of estimating what length of stay is going to look like. So us liaisons, we have access to we call it the case management calendar, and they've got on there all of the scheduled discharges through the whole month. And so as we're getting new referrals and we're meeting people at, the bedside, and we're talking with our case managers, we're just letting them know up front. I think honesty is the best policy. So if the patient's ready today and I got a referral today, I might have to tell them, like, we would love to help you, but we've got a room available on Thursday.
Okay.
So they might be ready to discharge Tuesday, but we can guarantee we can get them in on Thursday. But a lot of times we're just managing it, and people are leaving and people are coming, and we make it work somehow.
Okay. Well, that's fine. Like I said, that's one of the things, because I don't know, I've been on situations, because usually the hospital goes, they have to go out tomorrow and you have to get this thing figured out, and then
Yeah.
you're jumping through
Yeah.
all kinds of hoops to get that accomplished. So
Yeah. And I think whenever we're involved, and we have our territory, so we've built relationships with the case managers at those hospitals. And like I said, we try to be as honest as possible. And I think they know things happen, and I kind of look at it as those hospitals can't hold a bed for a patient either. So
right.
it is unfortunately the same thing. And we just tell patients and families, like, please don't worry about it. We'll do as much as we can. We'll take that burden off, and it works out.
Well, that's good. I mean, yeah, speaking from experience, that would be a huge,
Yeah.
because
Yeah.
there's many fretless nights and mornings chasing
Yeah.
things down. So
And we do have patients like with the Advantage plans and the commercial plans where an insurance auth to get them approved is pending. And, the doctor might see you at the bedside and say, you're ready to get out of here. But the case manager on the other side knows that we're waiting on insurance. So
yeah.
they can't kick you out.
Well, that's good to know. So 'cause you kind of get the impression you're going to be.
Yeah.
Yeah.
They're like, you're ready to get out of here.
Yeah. So I've had many nights where I've been trying to talk them into letting them stay for a night, because it's 1 o'clock in the morning. Are you seriously going to, so,
Yeah.
and it's
Yeah.
always seems to be, you're always in the ER from, I get these calls, all of a sudden you have to go to the ER, with one of them. And as soon as you get the call, say at 5 o'clock or 6 o'clock, they fell going to dinner or whatever it was,
Right.
and I know that I'm going to be there till 2 o'clock in the morning. It's just always the case, so it's just how that works.
Yeah.
So,
Yeah. Unfortunately, the ER is busy.
yeah. So, but it's just so, well, this is really good news that there are places like this that, because, I will be, right before we went live, I was to tell you, we've had some myriads of experiences, and it didn't matter if it was the prettiest place or if it was the not so pretty place. It's the staff that seems to make the biggest difference, is what I have found. And we've had really good experiences at rehab. I can't say that most of, either one, my mom, I don't think she's really enjoyed any of them. Okay. But,
Sure.
but she's had good experiences, and she's had some that we've actually just put her in a wheelchair and took her out, said,
Yeah.
and we may have made a hand gesture as we left. I'm not really sure.
Right. Yeah.
But
It's important to have an advocate.
yeah. So, and so it's, you got to pay attention to what's going on there. We've had good experiences at places as well. And so I do tell people about those all the time. Like, well, I can't tell you it's going to be good this time, but I can tell you that we've had good experiences, so that type of thing. So
yeah, definitely.
But I'm very excited. But I've never run into a hospital before. Most of them are senior living communities,
Mhm.
that maybe they're a nursing home / skilled living / rehab type
Mhm.
thing, or maybe they're another one that has a skilled wing with a rehab wing or something, so that's kind of what I've seen before. So you're new to me. You're kind of a new little model, at least in my world, from what I've
Yeah.
seen. Are there other ones like you in town, or?
Yeah. So the one I think that's been around the longest is a Rehab Hospital of Indianapolis, so RHI. And then Community has a couple. I know there's Community North, and I think there might be a Community South. Just recently, a Community West opened up. And then Riverview Hospital, I think, has like a small unit within their hospital that they consider an inpatient rehab hospital. And then West Lafayette has Lafayette Regional.
Okay. So these other bigger, well, Community North, I mean, it's a huge hospital. These different hospitals, so they just have like a little wing or a little floor or something, or?
I think so. I think Community West is like us and they're a separate building. But some of the others are much bigger because they also do outpatient therapy as well.
So you use commercial insurance, you use Medicare, Medicaid as well?
Yep. We're in network with almost everybody. We do pretty much all of the commercial plans, the Advantage plans. We're in network with the VA. We got that this January, so that was exciting. And then we do work comp as well.
Okay. So you work with a wide variety. So you could have
Yeah.
anybody from any age group in there as well.
So we don't typically take patients under 18
Okay.
because our nursing staff isn't pediatric, they're adult. We do occasionally take 17-year-olds if they're on like adult dose medications or their weight and their height, so that they can be treated as an adult, but typically we don't take patients under 17, 18.
And the stay is determined by, is it like what you've seen in a place where you have to be making a level of progress, or is it, how does that work?
A little bit. So that's really common in like subacute, like rehab at a nursing home. But ours is a little different because it's medical need as well. So patients have to need to see a doctor every day. So it's making that medical progress and making the functional progress with therapy, needing those two disciplines. Our average length of stay across all diagnoses is 10 to 14 days. That's, including TBIs and multiple polytrauma, but that's our average. I would say when we have an ortho patient, it's closer to 7 to 10 day. If it was from maybe a car accident, if it was a scheduled therapy, they might be there or a scheduled surgery, sorry, they might be there closer to the 5 to 7 day range. But our therapists work in teams. So when patients evaluated by PT, OT, they're assigned a team. So they get to work with the same PT and OT throughout their stay, which I love that we do that, because I just think that continuity of care is so helpful. And I think it's helpful for discharge planning too, because the same PT and the same OT are seeing you every day. So they can kind of tell like today's just a bad day, we're having more pain or something like that. So I think that helps get patients home quicker too.
I think that at least in my estimation, is the idea that you're a hospital, that you actually have a doctor seeing them every day, I think is highly unusual, at least in the, other rehab facilities.
Sure, sure, yeah. All of the inpatient rehab hospitals, like those ones I listed, they would all be doing the same thing. And then we at IRH, we have an in-house nurse practitioner who specializes in wounds. So we do a lot of wound care as well. And then any of those other physicians we can outsource. So we can bring them in because we're not affiliated with any of the large community hospitals in the area. We're investor owned, privately owned. So if a patient's cardiologist or a patient really wants their cardiologist to follow them, we can work on getting some agreement set up for that. But things like cardiologist, pulmonologist, psych, we just have those people come in and see the patients as needed.
No, very good. So, well, that's for, I know you've got a slideshow that you'd like to show, so I'll let you do that real quick so we can kind of see that. So that you
I
should be able to look at your screen. There should be a green button.
think we'll be able to skip most
There
of
you go.
it.
Well, go through it anyway. So yeah.
Yeah, no. So I started it with the introduction. I just wanted to put this up here because most of our referrals are coming from a major hospital, but we do get self-referrals. And specifically, I think a lot with planned surgeries. I just got a call today from a person who's going to have a surgery, and we encourage them to come and tour the hospital and see us as an option and just have that maybe planned out before they even go. They might not even get recommended for rehab. Maybe they get recommended to go home, but I think it's nice to have that plan before you even go.
I think that one of the things that's a big deal in that is, what I do to make a living is we have a company called Caring Transitions, where we help people downsize, pack, move, do all the stuff, that sell off their stuff, whatever. So I am often running into clients who they're on their own. They don't have family, or they don't have anyone nearby, across the country type thing. So surgery is a major deal. You go home, and if you've got someone there with you that can kind of help you out, but if you're going home to your cat, that may not be the the best, safest thing to do. So this is a good idea too.
Yeah, yeah. So we've got our main line on there and then fax. But yeah, if someone has a surgery plan, they can just come in and take a tour. So kind of what we started talking about was the different hospital levels. So this is kind of what I'm not going to read all that. This is what kind of everyone thinks about when they think of hospitals. So those are those large hospitals like IU North, St. Vincent 86, IU Methodist, Witham, all those places. And kind of like our level, they are seeing a doctor every day and they're typically still seeing PT and OT, but the goal is just to get medically stable so that they can discharge to the next place. Kind of like that, what that doctor said to you guys when you were talking about the muscles weakening every day that they're in the hospital. That's kind of the purpose of therapy at this level is to maintain what they can. And these are shorter stays, 3 to 5 days on average. But if a patient is needing to be there longer, maybe they're on a vent or something, they might find themselves at a long-term acute care hospital. So these are what we call LTACs. So in this area, we have Kindred LTAC and we have Seton Specialty Hospital, which is also an LTAC. So these patients are coming from those short-term acute care hospitals, but still needing the same level. And they're still going to see that team, a team of doctors, a PT and OT, respiratory therapist, speech therapist. Most of these patients aren't going to discharge to home. They are going to need a rehab hospital or rehab at a nursing home, maybe short term, maybe long term. And then our level, so inpatient rehab or IRFs, we're also an acute care hospital, but sort of like what we talked about before was the biggest difference is just the amount of therapy provided. Patients still see a doctor every day, just like they do at those 2 other levels of hospital. But the biggest difference is the therapy amount because the goal is different. The goal is to maximize their potential to get back home and get that independence back. This I think is important. I put it on there because I think this is probably one of the biggest questions I get when I go see a patient bedside is how do I know if I can go to an inpatient rehab or if I should go to a nursing home? So this is just a quick little bullet point of the differences. Like I said, our average length of stay is 10 to 14 days. It's a little longer at subacute because I think because you're not seen by a doctor every day and the therapy amount is different. Those are 2 of the biggest differences. And then also the amount of nurses. We have one RN per every 7 patients where subacute is often 1 RN per every 20 patients. So just things to consider whenever you're thinking about the difference. But I think the most daunting thing becomes the 3 hours of therapy. But I always tell people it's broken up throughout the day. There's a session in the morning, there's a session in the afternoon. And we do have patients sometimes that maybe they can't tolerate 3 hours a day at the start. So therapy can see them for 6 or 7 days a week to just be able to provide that 15 hours over the week. This is just a little chart of everybody that you might see if you came to our hospital if you needed it. So some of these things I've said, the 24-hour nursing care from RNs. We have respiratory therapists in-house that are available 24 hours a day, PTOT speech. We have on-site pharmacy, which I really love because, the doctor could see you Monday morning and want to make a medication change, can just text the pharmacist, and then we can formulate the change in-house most of the time. Occasionally they have something they can't formulate, so we do have to outsource, but I like that because, if a patient gets a UTI and we can treat it right away if we need to. And we do have on-site dialysis as well. We do hemodialysis. We do Monday, Wednesday, Friday with Optimal Dialysis is the company that we use. We can do imaging like x-rays. And we of course have registered dietitian on house. And then this care review, I think a lot of times we might overlook our case managers and the important role that they play. Because, they're meeting with the patients and the families and helping with discharge planning, helping them get home with all the equipment that they need as safely as possible. So we have 2 case managers, and our team meets every week to talk about kind of where each patient is at, what discharge looks like. Like you said, are they home alone with their cat, or do they live with their son? So kind of the whole picture, which is really important. And this is just describing what each profession is. Like I said, we have PM&R doctors who see our patients Monday through Friday, so they really specialize in the whole picture. And then our internal meds are seeing patients on Saturday and Sunday. And then I've just got kind of the breakdown of what each therapist does. So your speech language pathologist is there to tell you what they do. And then this is just a common list of diagnoses that could qualify for a rehab hospital. Obviously, we work with patients who aren't on this list, but stroke is probably the top thing that we see. Spinal cord injuries and amputations, brain injuries, and I put traumatic or non-traumatic because it might be traumatic like a fall or non-traumatic like a scheduled surgery. And then neurological deficits, you kind of mentioned Parkinson's. We work a little bit with the Parkinson's Foundation, and I went to one of those rock boxing classes a couple months ago. That was fun. And with going back we can admit patients from home, we do have patients who, we kind of call it a tune-up. Maybe you're having more falls, had a couple visits to the ER. Luckily, maybe the falls didn't result in injury, so you didn't need a hospitalization, but we do work with a lot of patients with Parkinson's. And I think these down below can be seasonal, like we're heading into cold and flu season. So we start to see a lot more patients with respiratory needs. And then I've got dysphagia on there since I said earlier, I'm a speech therapist, so I couldn't not include the swallowing deficits on there because we do a lot, our speech therapy does a lot with swallowing therapy because those strokes and those spinal cord injuries oftentimes do have trouble with swallowing. This one we kind of talked about too. So I'll maybe go into detail about my role. So as a liaison, I'll get the referral, which we kind of talked about. Most of the time I'm getting that from a case manager, and I'll get the clinical information from them. I first make sure we're in network with their insurance, which normally we are. Look at their clinicals. Are we a good fit for them? Can we help them? Do they want to do therapy? That's an important part too, right? Everyone has the choice. That's their right. If I have walked into a patient's room before and introduced myself and they said, nope, I just want to go home. So I kind of start there, and then depending on like age and if a person's having any confusion, I might reach out to family first. Normally the referral has the family contact, or if it says there's a POA, I'll reach out to them first, but reaching out to them and then going bedside and just meeting the patient and telling them who I am and why I'm there and what IRH is all about. We have a virtual tour, which I think I attached on the end of this PowerPoint. It's just a YouTube video, which I think is really helpful to show people at the bedside, because I would want to know what it looks like too, but we do always encourage families to just come in and take a tour too. And then if the family member wasn't available, we follow up with them and let them know, like, hey, I met with mom at bedside. Just wanted to let you know we approved her for rehab. We'd love to help out. And then patient and family make choice. And if they do choose us, then we kind of keep in touch with the patient. We like to try to go visit them every day, just keeping them updated too, so they don't feel like they've just been left in the dark. But then also talking with the case managers on kind of what we talked about. It's Tuesday. I know this patient is ready, but it looks like we can admit them on Thursday. Just everybody staying in touch. And then admitting, I do all that paperwork, kind of write the story. And then a lot of times case managers will set up transportation, but we are contracted with a few of the local transportation companies. So we can do that as well if they want us to. And then on the other side, I think we talked about all of that. We don't need that 3 midnight stay. We can admit from the ED and from home. We're in network with most all insurance plans, including the VA, and we work with work comp. The Medicare, that's the caveat with the 3 midnight stay. If it's a traditional Medicare, we don't need 3 midnight stay. We can admit them the same day. With the commercial plans, we still don't need a 3 midnight stay, but it's going to take about 3 days to hear back from insurance to get that approval. That last little blurb on the details is kind of what is the caveat. The biggest difference between needing an inpatient rehab hospital and going to like a nursing home for rehab is needing to see a doctor every day, needing the 2 therapy disciplines, and then anticipating progress. So kind of like what I was saying, occasionally a patient will say, I don't want to, or maybe they're even refusing therapy at the hospital that they're already at. So yeah, we have to want to do it, I guess. That's important. And then this is just our address. This is where I was gonna kind of go into IRH specifically. And just our mission and our values. I think the biggest ones are serving the community and delivering results with keeping the patients at the forefront. It kind of all goes hand in hand. And we are, I think I mentioned, we're investor owned. So like RHI, they're aligned with Ascension. I think community rehab is of course aligned with the community hospital. So we're not aligned with any of those big hospitals, which I kind of like because we're smaller and we can kind of be friends with everybody. We don't have any aligned providers. But we started in Texas. The company was actually started by a physical therapist. And we only do inpatient rehab hospital. So we don't have outpatient, we don't have long-term care. We're just rehab to home. We do discharge to subacutes if it's needed, but we always try to get patients back to their home. And that could be independent living, assisted living, wherever home is. I think we're up to 21 hospitals now across the US. We're of course in Carmel, and there's one more opening up, I think next year in either New Albany or Clarksville, Indiana. So there will be a second one in Indiana coming up. All of us have 40 private rooms with private bathrooms. There's a large therapy gym, which I think you saw when you were at the Chili Festival, kind of the heart of our hospital, because that's really the purpose, is the rehab. And then I've got our doctors listed there. Dr. Dugan, he's our medical director. Average length of stay is 10 to 14 days. Discharging to home. And then we recently started doing dialysis, so I put that on there as well. And we use a company called Optimal Dialysis, and they run patients Monday, Wednesday, and Friday. So if we get a referral who is on a Tuesday, Thursday, Saturday schedule, that's just something that we're working with the case manager and the patient's nephrologist at the acute hospital on getting them switched over so that they're ready and stable to start dialysis with us, which is important to keep in mind. And then I've just got some pictures of our hospital.
I recognize that room. So
yeah, a little snippet of our therapy gym. And then I wanted to include this one on the right. Is what we call our ADL suite. And that is where the therapists really work on the functional task. So it's a full kitchen. washer and dryer for a laundry room, and then there's a separate bedroom and a separate bathroom. So, you know, you don't really think about those things whenever you're in rehab. You're just thinking about standing and walking and getting some strength back, but bending over and getting the milk out of the refrigerator, things like that. Um, Doing the laundry, and then the bed does not have the grab bars, and then the bathroom doesn't have any grab bars as well. And that's not to show our patients that they're having trouble doing it, but that helps with the discharge planning as well, so that the therapy team can let the case managers know, hey, they're scheduled to discharge next week. I think they're going to need a grab bar in the bathroom. But all of our patients get discharged with continued therapy. So the case managers will help them get set up with either home health or outpatient therapy as well. And then this is just a picture of one of our hallways. So we have 2 hallways and we have 20 rooms on each hall. And then our nursing station is kind of the center of each hallway. And then there's a few couch and chair areas for families to visit. And then we do have a couple tables out in the hallway that maybe patients who need a cue when they're eating or drinking, or they just need a little bit of supervision. Oh, the lights went off on me again. Nursing staff can get them out in the hallway and join them for their meal and give them that little cue. And then this is a picture of one of our rooms. They all look the same, nice big window, which I love. Because I mean, that's a big piece of it too, is just getting that routine back. When we're in one of those major hospitals, we're sleeping a lot, the lights are turned off, the door is shut. So even just getting back to that sleep-wake cycle is a piece of the rehab. And then under the clock there, we have like a whiteboard, and we use that a lot. So they'll have their therapist names on there, their PTOT names, the nurse of the day. We'll have the patient write their own personal goals on there, what their motivation is to get back on their feet. And then PT and OT will update it, which I think is motivating too. On the eval, they might have walking 5 feet, and then in a week it might say walking 20 feet. So kind of keeps that motivation going. And then we do have 2 bariatric rooms, and then we have 2 isolation rooms. But other than those, they all look the same.
The private room's a big deal too for rehab, because that's not always the case. So
Yeah, I think it's important. I mean, thinking
unless
about
you get sleep and
yeah, you don't want a noisy roommate, that's for sure. And then I did include this kind of for the purpose we were talking about of including just our main line and fax number, but this is all of the liaisons on our team, and I included kind of which area we cover as well. So, maybe someone's having a surgery at IU University, they can call and ask to talk to Marcy. So just trying to help out the community. And then this last slide is kind of what I was talking about. I did attach our YouTube video that just kind of takes you through our hospital and what services we can provide. And then I had to include, we do a priority 1. So every time someone discharges over the intercom, you'll hear priority 1, and then everyone goes out to the front and kind of red carpet events and claps them on their way out the door. So I love that we do that. So I just had to include that on here.
very cool.
And that's all I got.
Well, I'll tell you what, that's very cool, sir. I think that I'm really glad to get this information out, that people know that you guys exist and that these options exist, because this is for families, this rehab process is a very stressful time, because literally from scrambling trying to find someplace that will take you, not having any idea what the experience is going to be at that particular one, so it's really nice to have a overview of what can be done. I love the fact that you don't have that 3 midnight stay as a hammer hanging over your head. Okay.
Right.
So so are there people that are not a good fit for this?
I think it would just come down to, sometimes the rehab, or not the rehab hospitals, the acute hospitals, but their rehab team, so PT and OT, they'll put in there, do not think patient could tolerate 3 hours, or considering patient could tolerate. So they're thinking about that as well. And that might be, if a patient's having too much pain, or they're having issues with blood pressure, but it's kind of that catch-22 of, we have a doctor seeing them every day too, so then our doctor can try to manage those things as well. So it's
Are they
one of those.
required to do the 3 hours if they can or can't, or?
So that's when we'll try to see, would they be able to do less time in 6 days or 7 days. So other than like thinking about something like that, I would say the only time they wouldn't really flat out be a good fit is if they're just refusing therapy, or the opposite, they're too high level. We do get patients who, I'll look at the referral and they're standby assist. So that means, someone just needs to be standing there, but they're doing all of their own care. They wouldn't need us, because they wouldn't need the functional piece, the intense therapy. So
Well, the
it
reason
just
I'm asking is
varies.
because I'm just thinking of different experiences that I've had, dealing with family. I recall once, and this was one of those ones that was a really bad experience. Okay, but
Yeah,
um, and I'm not going to say the name because it's changed hands 14 different times since then. But anyway,
sure.
but it was a situation to where my mom had an emergency where they had to remove a pacemaker
Hmm.
because it had become infected. And so when they did, they didn't get a chance to get her off of her blood thinners. And so she
Mm,
literally lost like half her blood when they were going through that process. So she now was a
right.
fall risk. She was a heart attack risk because of that. She had to build the blood back up. She went to therapy, and the doctor only wanted her there for wound care because he didn't want her getting up out of bed and trying things, because he was trying to get her blood built back up to where she'd be safe to do it. And they were constantly, and we called there and they said they would do, they had to literally unpack this wound and replace it periodically. That was the reason that she was there. Oh yeah, we have wound care. Oh yeah, we'll take care of that. No big deal. They constantly were fighting with her to try to get up and do all this therapy, which she was not supposed to do.
Mm,
And I found out they never changed the wound. They did the top dressing, but they never took all the stuff out. So she had to have it surgically removed later. Okay. So
oh,
not a good experience, but but that was one of the worst ones. Okay.
yeah.
But I've had other ones where, like mom had a situation, again, back to her. She actually had a reaction to it. Took us weeks, maybe it was months before we found out what it was. She'd actually, I think we talked about this at the event, but she actually had finally the ninth neurologist figured it out. She had a reaction to the COVID booster, and
Hmm.
it's ever since then she has seizures, and so they'd have to have her on anti-seizure stuff. But she was having, where they would get her up, she'd go, I could feel it coming, and the hospital decided that she was not trying hard enough. They sent her back to rehab, because they were saying that she was nuts. But they actually basically kind of said she was mental issues, and
Yeah.
she just kept saying, "I'm going to fall. I feel like I'm going to fall." Well, they took her back in on a gurney. They put her on the bed, and she had a major seizure. And they all saw. They put her right back on the thing and took her back to the hospital. The hospital was much nicer after that. Okay, but and then she was in and out of that rehab for quite some time. But now she's doing great. But they got her back on her
Good.
feet. They just
Yeah.
finally figuring out what it is and getting the therapy needed. So I'm a big advocate of therapy if it's
Yeah.
applied properly. Yeah. So
Right. Yeah. And most of our referral sources, like I said, most of our patients are coming from those major hospitals, and their therapy team and their doctor are kind of the ones driving that decision. And it will say right there in the referral that we get, patient needs acute rehab, patient can tolerate 3 hours of therapy. So that is where most of it comes in play.
let's say you have someone come in, they go, well, I think in a couple of days they could be up to 3 hours. Do you still take them for that and then build them up to that level, or?
Yeah, yeah, if they're making that recommendation, and
Yeah.
that's when our therapy allows them and they can start trialing with the 6 to 7 days and then hopefully get them down to the 5 days a week.
Okay. Well, very good. Well, this is exciting. I'm glad to get this information out there. I'll have you this video, I'll get you a copy of. You can do with what you want. And then I'll also it'll go on Life's Copilot under the resources under video library. It'll also go out on our monthly newsletter, which will go out, and then it'll be on social media and all that kind of stuff as well. Why don't you say how to get a hold of you one more time? Just, I know it's on the screen here, but just.
Yeah. Yeah. So my direct work number, it's 463-333-9079. But our main hospital number is 463-333-8429.
Well, thank you very much. Is there anything else you want to get out before we call it a night, or?
No, we just love what we do. I know
All
that
right.
sounds
Well,
corny,
thank
but
you
I'm
so
like,
much.
I
I
love
was
it.
so glad to meet you guys and find out what you did. So we will talk soon.
Yeah, thanks for having me.
Thanks, Sarah. Bye-bye.
Bye.